everybody. How are you today? Great. So, you already know about us. You already know about the organization. You could see me afterwards. But today's program, we want to thank one of the pharmaceutical companies for giving us the funding to do today's program, and that would be Teva Neuroscience, and I hope that you all thank them as well. So we really rely on the pharmaceutical industry to give us the funding to do all of our programs, and they want you all to learn from the programs that we provide and the video recordings that we do with these programs as well. So again, I mentioned before that we're going to have some dialogue today, 45 minutes of the two clinicians. Marie Moore, she's a nurse practitioner, which you probably know about in the area, and Dr. Max Carraro, and he's newer to the area, but he's bringing in some great information as well. And so we want to thank them and have them come on up right now. They're all the way in the back of the room. It's going to take them a few extra moments to walk up. They think there's a red carpet here or something, you know? Come on down, the price is right. You can even use the steps, or you can come straight on up. That's great. All right, so we're just going to get started on today's program, okay? You ready to talk?
Ready.
Ready. Go for it. Thank you.
All right. So thank you, Stuart, for having us. This is just a huge privilege to be able to speak openly. So many of the talks that we do, we're restricted to what the FDA will let us speak on, and though it's wonderful to have those opportunities to share information, this is truly a pleasure to be able to really speak freely regarding MS. Here we go. So I'll just start by asking you, what are some things that you like for patients to know about MS as just kind of a foundation, a ground-setting place to start your relationship?
Sure. So to me, it all starts with MS is unique. So I always say, you know, if you had a twin with MS, it would be different MS. So we got to figure out what your MS is all about. And to me, that's what the first visit is. It's getting to know each other. I think we'll touch on this again, but getting a feel for each other's style and does that mesh, because it's very important that you communicate well, that you trust each other, and that you're sort of on the same page with, you know, how you're dealing with the whole picture, emotions and treatment. And so spending time getting to know an individual's MS, so you have a sense of where you should go with treatment and other sort of strategic planning for future success. That's where I like to start things, and what that involves is, you know, very thorough history, very detailed exam, including the EDSS score, looking through MRIs together. I think that's very important. Everybody knows the old adage, you know, picture's worth 1,000 words. So an MRI with multiple pictures is worth more than I could ramble in hours. So we always review MRIs together. Talk through many different aspects of that, which I think we'll get into again later, and then sort of do a summary. You know, so what does all this mean? Talk a lot about prognostic factors, because I think that it's so hard, especially the younger you're diagnosed, we're so much in the moment of our life, and we're not thinking 20 or 40 years out, and that's very hard to do. So, you know, how do you get people to see? We're not planning for next week or next year. We're planning for that plus 20 years, that plus 40 years, and trying to take all that information about their disease prognostic factors and look into the future as best as we can.
And I totally agree with you. And I think it's important, or something that I want patients to understand, is that when we're talking to you and asking questions and hearing your story, we're also thinking through, okay, what does this picture look like to the best of our understanding of MS and the data we've reviewed. And I certainly use a lot of research to inform the recommendations and advice that I give. That does not mean that patients have to do that. And I think that's a really important point you made. The patient is an expert in the patient. We have some expertise in MS, and the perfect relationship is one where we really work together to come up with the best plan for that patient. And that plan may change with time. That plan likely will change with time.
Yes.
But at any given point, we're trying to give you that knowledge, and it's knowledge that's really informed on the research that we have.
Yeah, it's sort of like a guide. This is a journey. MS is a chronic condition. We are trying to help steer things the way that you want to go. So identifying goals. You know, do you want to have kids? Do you want to train for a marathon? Do you want to retire by a certain age? What are the goals? We're just trying to help you reach them, right? And I think another job of ours on that note is to set the bar high. So I'm stealing this, but someone who I know well, who helped train me, said, you know, if you are starting off as a sports team in college and your goal is to win the national championship and you come in second or come in third, that's still pretty good, you know, still a successful season. And so we should set the bar high. We should have high expectations.
And I think that understanding patient goals is just a huge part of that. And that's something where in our current healthcare environment, that requires time, right?
Yes.
And I think that that's the hard part, is that you've got so many things that we want to discuss and need to discuss in an office visit, that getting into that is equally important, though sometimes easily kind of skipped over, I think, in certain visits and encounters. And so I think that that whole picture is something that is just imperative to take into mind as we're developing goals.
And I think that's the thing. It takes time. And one of the advantages of being at, you know, an MS center like the ones that we're at, you have more time. Yes. It's like an unfair advantage in terms of successful treatment. But we have 30 minutes to review what has been going on, delve into symptoms, address symptoms, explain why it's important to maybe modify behavior so that you can sleep better, so that your headaches improve. It's not just a quick, how you doing, you know, check next visit, or here's a pill for something, but really getting in depth.
Agreed. So you mentioned prognosticators,
yes.
And I think that that's a really important concept for patients to understand, because that is very much a part of how we recommend and make treatment advice. So would you go into some of the different prognosticators that we use?
Yeah, so much of this comes from very large natural history studies, right? And that's the era basically before we had disease-modifying therapy. But these are humongous cohorts of patients that came from all across the world, and they basically, they studied them over decades in many cases and said, so okay, if at the onset of disease, this is what was going on, what was the outcome 20 years later? What was the outcome 30 years later? And so we have a very robust data set to help us figure out what looks like it might be favorable and the opposite. And so a lot of the disease prognostic factors come from that. And so to make it simple for myself, I just have that listed in every note for a new patient visit so that we comb through them. And there's demographic factors, there are MRI factors, and then there's clinical factors. And so if you start with the demographics, what we have seen from those natural history studies is that males tend to have a more aggressive course of MS. If you're diagnosed over the age of 40, you tend to have a more aggressive course of MS. If you are non-Caucasian, you tend to have a more aggressive course of MS. And so those are some of the general demographic stuff. If combining environmental, low vitamin D levels, which is, I don't want to say controversial, but it's sort of hard to prove causation with that. But there's tons of studies about vitamin D, and it seems to be fairly accepted consensus that we want levels to be high, right? We want them not just at the 30 or whatever the cutoff is, but we want them 50, 60. And so I think most all of us will supplement vitamin D. Smoking exposure is bad for you. It doesn't have to be you smoking. It can be secondhand exposure. And then there's other things like childhood obesity that studies are coming out showing that that's a problem. And even maternal levels of vitamin D. So while you are pregnant, what is your level of vitamin D and how does it impact the offspring? There's studies looking into that. There's studies looking into low salt diets because high salt seems to disrupt the blood-brain barrier and maybe allow MS to do more of its thing. So that's some of the socio-demographic stuff. There are aspects, like we said, clinically. So how many attacks have you had in the first year? Are they occurring back to back? Are you recovering from the attack? That's a huge one. If you have an attack and recovered, that's actually pretty favorable. Having an attack and not recovering from it should put us on our heels a bit. The type of attack you have is important. So if it's a spinal cord attack, I mean, I think we pay attention to all of them, but that's something where you really pay attention to. A brainstem attack, you know, where the symptoms of the lesion would be coming from the brainstem, the cerebellum. And so those are some of the things clinically that we look out for. And then in terms of MRI, the number of lesions at diagnosis. So the more lesions you have at diagnosis, the less favorable. Having a lot of T1 lesions or black holes, having early brain shrinkage or atrophy, spinal cord disease, and then infratentorial, again, is just brainstem or cerebellum. So infratentorial disease, you know, none of those are favorable in terms of prognosis.
And I think that that's so important to convey, because often when seeing a patient, either at the beginning of the journey or even a few years into it, when we're making treatment choices that may be more aggressive, that may have potential for some significant side effects, these are the factors that are running through our heads when we're trying to make these recommendations. And what we see from research and from those larger trials of patients where they've been followed out even after the end of certain clinical trials is that we see that the better job we can do of really shutting the disease down early, the better the outcomes are long term. And I think that sometimes is a hard concept, because patients will say, but I feel fine, I'm doing fine, I'm functioning fully. Do I really need to take that step? And my mentor, Dr. Kaufman, would say, I would much rather try to tame a horse while he's in the corral than try to catch him once he's out. And I kind of think about that often when I'm working with patients. They feel fine, they're doing fine, but we're looking at these factors and we're seeing maybe things we don't like on MRI. Perhaps patients have symptoms, though mild, but they've got mild sensory, mild tremor, things that are symptoms that make us more concerned for long-term prognosis. And that's what really informs the decision to really encourage patients to take on perhaps more aggressive treatment. And it's, again, because what my goal is for, you know, patients to do well long-term. And I think that, you know, trying to meet those goals, match those goals together with the patient is really important.
Yeah, and one of the things we use, I want to come back to, I have a question for you, but I like using the MSSS, which is the Multiple Sclerosis Severity Scale, and that basically takes the EDSS, or the disability score, and puts it in a chart over time, and it shows, you know, where your EDSS is, how many years on disease, and it converts it to this MSSS number. And then you take that value, and it's basically a decile of severity. So even if you have a low EDSS, but you're only a year or two into diagnosis, if you follow that trend over time, it sort of gives you this visual into the future. It's even color-coded, so it's very easy, I think, to connect emotionally to it and say, whoa, yeah, I do feel fine now, like you were saying, but am I going to feel fine if in 10 years my EDSS is 6? And I like to use that because I think, again, just that visual is very impactful, not only for patients, but for me, to be honest. I mean, if you see, you know, if I see somebody and they look great, I'm feeling good. But our goal is to keep it that way. And so it's important to remind ourselves, too, that we're shooting for that long-term goal. And so you were just mentioning, again, like the use of early treatment, like as soon as possible. What is that conversation like for you in clinic?
So after diagnosis, or even before a diagnosis of clinically definite MS, we have really good data now that suggests the earlier we treat, the better. And what I mean by that is even after a first attack, so what we call clinically isolated syndrome, or that's been the title it's been given for some time, even after a first attack, we're really encouraging treatment. The conversation that I have with patients is, first, I try to get a feel for where they are with this. What does this look like for you? How are you doing with this diagnosis, especially when it's new and the whole world has been rocked, really? And though I may think in my head, gosh, I would really like to have this patient on a more aggressive therapy, if that patient is just not ready emotionally to take that on, my goal early is I just want to get you on treatment. That's my first goal. And so once we do that, then we can begin to see, I think the use of MRI, we've kind of hit on this somewhat, but the use of MRI is imperative, especially early in the disease. We want to get an MRI 6 months after any treatment is started. That's how we do it. Because I want to see how the patient is responding, and then we're going to do one within a year after that. And so what we're really wanting to follow closely after a treatment is started is, do we have complete control based on the parameters that we're able to measure of this disease? Because if we don't, we need to have a conversation. I know that you are a firm believer in NEDA. NEDA is this concept that's relatively new in the MS world, but do you want to speak to that a little bit? Because I think we share a lot of that concept.
So this, to me, is one of the beautiful things that's come out recently in MS, because it's it's so tough. There's no consensus regarding treatment options, which makes it very challenging for patients and also hard for us too, because you're saying you might want somebody on a certain treatment, but it's hard to communicate that, and it's hard to show, like, cancer, for instance, has these beautiful guidelines that really show you, based on stage and all these other factors, what the possible treatment options are. And they're very firm recommendations. We have the opposite. It's kind of crazy. So it can feel like shooting from the hip for both us and patients. I think, at this point, we have our own way of doing things for reasons, but NEDA helps give it a context, I think, for all of us. Anybody who is able to touch MS in any way. And it's this concept that's changing over time. We're on our 4th iteration of it, so we're a NEDA 4. Some people are pushing for a NEDA 5. But basically, you want no new MRI activity, so you want no new T2 bright lesions. You want no contrast-enhancing lesions. You want no new T1 dark spots. You want no clinical attacks. You want no change in disability or progression of symptoms. And then the aspect that's been a little bit harder to get into clinical practice is you want no change in brain atrophy. And that's challenging because just using traditional MRI, trying to use the little measurement stick tool on there, it's not very precise or reproducible. And so I don't trust that as a measure.
I think that that's probably something that's used very much in research, but I think clinically in kind of real world, we're not seeing it yet. That doesn't mean we won't, but it's not here yet. And
it's coming though, and it is in clinical practice, right? But it's just not everywhere. So there's different software programs that a system can use, and they do quantitatively measure brain volume or atrophy, and so you can apply NEDA 4, but it's just a little bit more challenging. But again, we said at the beginning, we want to set that bar high. I do not want my patients doing good, or fair, or okay. I want them doing great. And I think that NEDA is a very concrete way of helping us achieve that. It gives us objective measures. And so setting that bar means doing things like you were saying, MRIs every 6 months. If you're changing therapy, start a therapy, give it time to work, get a new MRI. And before you change therapy, you should do a baseline MRI to see this is where you were, then you put a therapy in place, what happens 6 months later.
And I mean, obviously insurance is going to impact that, right? We can't, the unfortunate thing is that we can't always do what we want to do. So then we try to come up with the best solution that matches the patient's financial abilities and what we want. But patients will often ask, do I have to get another MRI? And granted, if you enjoy MRIs, that might be another conversation that needs to be had. But at the same time, there's a reason. We're not just ordering because we feel like it. We're really using that data to inform treatment choices. And I try not to order an MRI unless it will inform a treatment choice. But when I'm ordering it, it's because I want that information to either make sure that we are on the right treatment or to discuss making a change and having the information that's needed to inform that change. One point I did want to make, NEDA stands for no evidence of disease activity. I don't think we actually said that, and that was my bad. So with that being said, we've kind of talked a little bit about the concepts that inform our treatment, but empowering the patient to be an active participant in their care is a really important thing as well. It kind of hurts my feelings a little bit when patients come in and like, oh, you're going to be mad at me. I'm not taking my treatment. Well, I'm not mad at you, but I'm kind of hurt that you didn't let me know sooner, right? Because if you're not taking your treatment, then we got it wrong, right? We've got to do something different. And the thing about treatments is everybody tolerates them differently. And I can kind of have a concept in my head of how a patient will tolerate a medicine based on my experience with a number of patients, but everybody's different. So I think that, and what I try to do is just really encourage patients, gosh, if you're not doing well with this for whatever reason, let's talk about it. And sometimes that conversation comes back around after we go through options that, you know what, actually this is well, let me kind of double down and work on this. I think I want to stick with this. Or it might be, you know what, I think option XYZ is going to be a much better fit for me. But it's being able to really have that open dialogue. And something else we were talking about before this started today, not every provider's personality is going to sync perfectly with every patient's personality, right? And so I think that that's a huge point in empowering patients is be your own advocate. If you don't feel that you can have an open and honest conversation with your provider, consider seeing someone else to see if you can find that better fit. Because at the end of the day, this is your life, right, as a patient. And who better to determine who you can have that good fit with. Now, that doesn't mean that if I have a good rapport, I may not say something a patient doesn't like. I want to be honest and transparent with assessment, but we should be able to have that open communication. And I think that that's just really important. Something else I think that helps patients to really be proactive in their care is to write down the things that you want to discuss at each office visit. Oftentimes patients will bring in their list and they're kind of embarrassed about it. And I'm like, I love a list, right? Because that lets me know what your concerns are. Now, I think it's important to prioritize that list and put the top few things that are most important to get out of the visit because we are constrained by time, like it or not, right? I unfortunately can't spend 2 hours. It's just not going to happen. But after we've gotten through the logistics of what we have to get through in a visit, looking at MRI, looking at exam, labs, etc., then that kind of can really steer the visit and make sure that you're getting what you need out of that visit. So hopefully this is a two-way street at any appointment.
Agreed. Absolutely. And another thing that helps that is it's so hard to be objective. So who knows, old quotes, they're always attributed to many people, but there's this great quote attributed to Ben Franklin, who knows, that says there's 3 things that are tough: steel, diamonds, and to know thyself. So if you can, heard that, but I like it. Bring somebody with you, friend, family, roommate, whatever, but someone who can help say, I'm seeing it through a different pair of eyes. And what I notice is, you're moving around a little bit more slowly throughout the house or whatever. Just the subtleties that you might not pick up on, but somebody else can.
And so often, right, you've had this happen. So you're asking, you've got a husband-wife team, right? So you're asking the patient, whichever it is, how are you doing? They're like, oh, I'm fine. And then you've got the spouse going, like in the background, right? So that's where this is helpful. And it's not because the spouse is trying to rat them out. The spouse cares, right? And hopefully. And so anyway, I think that is very important because you get that information. I can say, okay, would you mind if I ask your spouse why they're shaking their head about this so that we can get a better understanding of what the real picture is here. So that transparency, though, again, both between the patient and the provider, but also having that other person that cares about you there can be really, can make for a really impactful team, I think.
Mm-hmm. And you really should, just to reiterate the point you made, advocate for yourself. This is about you. I don't care if you're going to see a specialist or a subspecialist or something that sounds fancy. We're just people. We're trying to help people. But it is about you and your care, and so advocate for yourself. Right.
Yeah, and everybody has a bad day, right? Yeah. But at the same time, if you're consistently having a hard time with your provider, I think that's just important to appreciate. You know what? I'm not getting what I need out of this relationship. Let me see if I can find a relationship that would be more fruitful. Mm-hmm. So I'm going to kind of switch gears here a little bit. We had talked a little bit earlier, too. A question I often get is, what is a relapse? And I think that's a very important question. So what is a relapse?
What is a relapse? Mm-hmm. So first of all, what about the term relapse versus attack, exacerbation, flare-up, something new happened? And it's important to note that in the clinical trials, so we have all this data, such and such reduces the annualized relapse rate. That's great. The definition of relapse in a trial is very strict. So it's a little bit different, most people feel, than what we actually do in the clinic, in the real world. We don't set ourselves to these extremely specific guidelines that are a part of a clinical trial. And so the way that I try to describe it is that you did not have a symptom Sunday, and then Monday, this symptom appeared. And it didn't come and leave in an hour. It came and it hung around, and it lasts definitely more than 24 hours, almost always more than 48 hours, and it tends to sort of crescendo a little bit, spread, worsen in severity, and then sort of, level off, plateau, and then usually improve. In MS, the attacks usually improve to some extent, 50%, 90%, or sometimes resolve completely. So you sort of have this arc of a relapse, but you should be able to find an onset. Well, I woke up and this was happening, or in the middle of my workday, I couldn't see my computer screen. But there should be some definite onset like that. And then, so the rule I give patients, this is the homework, is if you have a new symptom and it lasts more than 24 hours, call. Just let us know. You don't have to figure out, is this a neurological, acute exacerbation?
And I like that point, and I try to make that point often, is it's not your job to figure this out. That's what we're here for. So if you've got something that concerns you, let us know. With time, you'll begin to figure out, hopefully, your disease, and you'll kind of get a better feel for maybe when a symptom has gotten worse and have an understanding for that and what that looks like versus a new attack. But kind of my buzzwords I give patients: any new neurological symptom persistently present for more than 24 to 48 hours, I got to know about that.
Yeah. Yeah, and speaking of communication, right? Like, don't hide the fact that you're not taking a new drug or a new disease-modifying therapy. And don't hide the fact that you have a new symptom. This is a constant stream of communication. Ideally, although there's headaches with it, the new medical record systems help. In Epic, there's My Chart. You just type a note. It's like sending an email. You can do that any time of day or night. You don't have to wait on hold. You don't have to leave a message. And then we can get back to you quickly as well. But we need to know. So coming in 3 weeks later, oh yeah, last month I had such and such happen, and we're going,
yeah. And that's because when we truly suspect that this has been a relapse and new neurological symptom, if we're going to treat that, we need to do that within the first week of that symptom. Maybe within the first couple of weeks, but really beyond that, if we're going to use steroids or something like that, they're really not going to have any benefit after that first week or two. Something else that we had spoken about is the fact that though a relapse can be very anxiety-provoking, it's nerve-wracking to all of a sudden have something going wrong, right? That's clear. At the same time, it's not necessarily an emergency that should send you to the emergency room. And the reason I say that is, what if a symptom starts on Friday afternoon and you're waiting your 24 to 48 hours, it's now Saturday afternoon, maybe Sunday morning, and you think, gosh, I'm having a relapse right now. I tell patients, you don't have to go to the emergency room. Nothing is going to be hurt by your waiting until Monday to call the office, because I don't want patients necessarily going to the emergency room being maybe even admitted, which we kind of talked about too, hopefully patients are not being admitted for steroids, but regardless, going to the emergency room, being exposed to ridiculous wait times if it happens to be a busy weekend, being exposed to infection and everything else, that's just not necessary unless the attack is one that merits emergency treatment, such as severe bladder retention where you're unable to urinate. Now, that would be a reason to go to the emergency room. But new numbness, new tingling, even new weakness, that type stuff, optic neuritis, it's fine to wait until Monday, but you definitely need to call on Monday and let your provider know, gosh, I'm having this is when it started, so they can get that treatment. The other thing that we have to think about with steroids, and I think we're going to just talk a little bit about how we each treat relapses, but steroids definitely have their fair share of really ugly side effects. In our practice, we don't treat every relapse with steroids. I'm typically going to treat a relapse with steroids when we see functional impairment. So significant weakness that's putting patients at risk for fall, or visual issues that are going to really impair a person to work or maybe care for children, et cetera. So those relapses that have functional impairment, that's when I'm going to use steroids. Let's say a patient has a sensory relapse in which they have paresthesias, but it's not stopping them from doing anything that they need to do, not impairing their ability to function. I'm not necessarily going to treat that, and the reason is patients are going to improve as much as they are going to improve. What the steroids do is just help to increase how quickly that improvement occurs. So that's how I tend to treat with relapses, and again, the whole reason for this is because steroids are not a benign therapy. We definitely can see significant side effects from steroids, anxiety, it's being one of the more acute things, but long term we can see avascular necrosis where we have, I've got young patients who've had bilateral hip replacements. You can see really ugly stuff from steroids. There's a long list I'm not going to get into right now, but that's why we don't treat everything. But I say that also to say, if you talk to a room of specialists, you would get that many different opinions on why they would treat, so I think it's just a very individual treatment preference. I'll let you speak to kind of how you look at this.
Yeah, and part of the issue with this is, again, data. So most of our understanding of treating a relapse comes not from MS relapse treatments, but from these optic neuritis treatment trials. And we're both laughing because they weren't perfect trials, and they were relatively small, and they're old, and they didn't use the doses of oral steroids that we would use. And I don't know that it applies. I really don't. And it was for optic neuritis. What does that mean for transverse myelitis? Can we, these are all different things. So that's why there's and you'll hear this throughout today's discussion. You'll hear this if you've been to different specialists. We all try really hard to take all the data and apply it in a smart, thoughtful way that will help people and not hurt people. But you're right. Steroids are not benign, and so you do have to pick and choose when you use them. And sometimes it is hard to say, well, if we're going to switch your disease-modifying therapy anyways, and you're not having some impairing symptom, do we have to treat? And a lot of times I'll leave it up to the patient. We go over risk. But if they're bothered by the symptom, that's okay. I wouldn't want to live with the symptom, and I think if they're want to be treated even for a sensory thing, that's totally fine. But those risks are there, and as long as everybody's discussed them and aware, then I'm okay treating. But I totally agree. Anything motor, balance, spinal cord, brainstem, I'm treating. I tend to be super proactive in treatment in general. It's sort of like an optimist about this, like, we can do it, we're going to get in there and do it, rather than take the more watchful approach. But there's definitely no right answer, so it's a conversation. And I think another misunderstood thing about treatment of a relapse is everybody, like you said, thinks they have to go to the hospital for 5 days of IV steroids, and that's not the case. You almost never should have to be in the hospital. I think that's doing a disservice, and again, as Marie said, exposing you to more risk. So there's oral pills. You can take 25 pills of prednisone for a total dose of 1,250 milligrams. That's a lot of pills. It tastes nasty. It's for 5 days, just like the steroids. And there are Decadron, which is a compounded pill. It's 200 milligrams, but it's a single pill you could take for 5 days. Sometimes the cost is a little bit more because it's through a compounding pharmacy, so it's not through insurance. But usually in the range of $30-ish, one pill a day for 5 days. You can also, in some cases, I have not done this, but drink the Solumedrol. Make a little cocktail with some OJ, maybe a little champagne, mimosa.
It's a way to get it in, right? It's a way to get it in.
Yeah, but it's a way to get it in, all joking aside. But my point is there's different options, and I think the thing to know is you don't always have to treat. Like you said, and you almost never should go to the hospital. But you need to communicate.
Absolutely. And there actually was a good trial out of France a few years ago where they compared equivalent doses of IV and oral steroids, and even in optic neuritis, which we have this bias on, but and they really saw that patients did equally well with oral versus IV. And I think that's really important for patients who are trying not to miss work, who maybe can't get away from their life to go get an IV. It's a nice option to have when it's needed, for sure.
And the initial way we treated relapses, I was not alive. This was in like the 70s. I was almost alive. We used this thing called adrenocorticotropin hormone, ACTH, and basically what happened is they almost stopped making it, and so physicians at the time said, "Gosh, we got to do something," and they used steroids. And so what ACTH is, it's the hormone that tells the adrenal glands to make steroids. So rather than giving steroids, you're giving a hormone that makes the body make steroids. So it's back. It's branded as Acthar. And the benefits of this are that you can do it even if you've had a vascular necrosis of the hip. If you have brittle diabetes and your blood sugars go crazy, or high blood pressure and your blood pressures go crazy.
Steroid-induced psychosis is also a reason we would use this.
Yeah, and there's all these different nuances where you'd say, I think we can use Acthar, and the way it's given basically is it's a tiny vial, you drop 80 international units, and it's a tiny needle sub-Q injection. So speaking of convenience again, you usually get your first dose in the office, trained on how to do it, and then you can go home and do the rest yourself over the next 4 days. So very convenient. It's crazy expensive and like stupidly expensive. So we're not just jumping around using it, but it's this sort of second resource we can pull in when needed.
So, but the goal obviously is to prevent relapses, right? That's why we, thankfully we talk a lot about medications, and what a blessing, right, to be here and know that 20 years ago we had just gotten our first therapy, really, and to have 17 therapies now is just a huge blessing to have options. And I think that really goes into, there's just not a reason why a patient with relapsing MS should not be on some type of therapy. There's just really not an excuse. There's that many options. We can come up with something that will give you some control over this disease and hopefully prevent the long-term devastation that so many patients have had to live with for centuries, right? So, so with that being said, our treatment landscape has changed, and I know the way I treat today is different than the way I treated even a couple of years ago, not to mention 5 years ago, 10 years ago, or 15 years ago when I started my career with MS. It has changed exponentially. And I really love that we have programs like this where we can really educate a bit on these therapies, because I will routinely see patients who have seen other providers who maybe don't have as much of a inroad into MS therapies, and they're on treatments and yet continuing to have relapses, have new MRI lesions, and their disease is progressing unnecessarily. And I think the more we can get the word out that there are ways we can treat, the better. So I'll let you start this conversation. We can kind of have a back and forth about the treatment.
I think that's where to start it, right? Going back to the high bar, to NETA or NETA, no evidence of disease activity. The way the treatment was of, you had a relapse, but that's not unexpected, and keep on going with the injections. No. That's not doing enough. I feel like we have great data to support that. I feel, as we already mentioned, that there's great data to support early intervention. And I also feel, based on the data, that it's early intervention with highly effective therapy. And you'll often hear, and I'm not being nitpicky, but I always point this out. So we've even used the term aggressive for some of the DMT, the disease-modifying therapies, DMTs. I don't like that term. Why is it aggressive to try to prevent a disease that attacks the brain and spinal cord? It sounds appropriate to me. And so one of the things that I do is we go through the disease prognosis, look at MRIs, blah, blah, blah. When we get to the conversation about disease-modifying therapy, I ask my patients, okay, so now we got to get ahead of this. Do you want to be on the most effective medication that we have or the least effective medication? Without fail, 100% of my patients, I'm really, this is legitimate, 100% of people say the most effective therapy. So why aren't we treating like that? I don't understand it. And I think that part of it comes from, like you said, the turnover has been so fast. It's like drinking from a fire hose if all you do is MS, like we do. So it's hard to stay current. It's hard to stay up to date. The newer therapies are more involved from the provider side. They take more work. They're harder to explain. They're harder to monitor.
Harder to get started.
Harder to get started oftentimes.
I mean, I understand why those whose neurology practice is not dedicated to MS may not use certain ones of these drugs. It is labor intensive. So that is not to be underplayed at all. It is labor intensive.
It's real life.
Yeah.
It's true.
Yeah.
It's just the practicality of it. And again, like you said, getting on a treatment is the goal. It never has to be one treatment. And I think the beauty of today's landscape is that there's so many options. And so, for instance, first therapy beta serum, 1993. You get a couple more injectables in 96. And really, you're collecting injectables that they're all interferons, and then there's Copaxone. And you get natalizumab as the first game changer in 2004. Really started coming into use 2005 and quickly got pulled off because of PML. Then it came back in 2006. But it still was difficult to use because we couldn't really stratify risk. So if you just fast forward a little bit, 2010, we get the first oral pill. What a game. I mean, I can't imagine the emotional difference between having that option available. And then we've had 3 pills come out, and Tysabri sort of came back, natalizumab, because of this stratify test, which basically checks the JC virus, it checks the antibody, and it gives you a level, and they call it the index or the optic density. And we can put that to use and give somebody a % chance of developing PML over 2-year increments. And so it's very different to say, well, PML happens on this drug, we don't really know how much or in who, and saying, well, your level is low positive, and your risk over the first 2 years is 0.006%. That's pretty low. Most people that I have this conversation with, they have no issue with that risk. So even though they're positive for the antibody, their risk is so low, and they're ready to go on it. They want to go on it.
So I have been treating a little bit longer than Max, but I mean, I remember the days where we didn't have JC virus antibody testing, and when we put patients on this, it was, okay, the way we did it was, we're going to treat for a year. We know that the first PML cases showed up at months 13, right? 13 and 14, I think it was. So we're going to treat for a year, we're going to bridge you with something else, then we're going to, maybe go back. So it was this whole thing, and really the stratify, the ability to test for that test, for the JC virus, which, by the way, over half of the American population carries this virus. You didn't do anything to catch it. You wouldn't know that you have it. It doesn't have symptoms that we understand or know of at this point. The only way you'll know if you have this virus is a blood test. So there's nothing you did wrong to have this virus, and there's nothing you do wrong if you catch it. It's just one of those kind of like herd type immunities that we see. But so just kind of want to put that out there. But regardless, that really changed our ability to kind of better calculate risk with this tool that has been an amazing tool for a long time. But the cool thing is we have now many other tools in our armamentarium. And I think the PML risk is actually an important conversation to have, because we've got some of our orals that have some PML risk associated with them. And I have patients who are like, I don't want to take any drug that has any PML risk, but I often will say, well, let's talk a little bit about that, because we've got, a handful of cases with our oral therapies, hundreds of cases with PML, with Tysabri. So the risk for PML is very different between the orals that have been associated with PML and Tysabri. And I think that that's just an important point to make. And we can obviously get into specific numbers in the clinic if this is a treatment choice that you're debating with. But I think that understanding that the risk is far different, even if you're JC virus positive, between Tysabri and other therapies, is a really important point to understand.
Yeah, and the emotion of hearing something like that is impactful, and it should be. But again, it's important to try to make, the best choice for yourself and really understand what that risk means. So I always say, there have been cases on Tecfidera, Gilenya, but you're talking about 5 cases and 10 cases out of over 100,000 people on each drug, well over 100,000 people. Your risk of getting in a fatal car accident is tremendously higher than that. And I never think about getting in a wreck when I'm getting in my car. I do it multiple times a day. So it's trying to put the risk conversation in a context, not only in terms of other things that we do, but in terms of the MS itself. So to me, MS has a risk, has a tremendous risk, and we know it because of natural history data. We know what happens when you don't treat. We know what happens when you undertreat. And that's the point of the disease prognostic factors. Like, there is a risk here. We can't ignore the risk of what's going on every day for the rest of your life, so let's try and do something about it. And that's another way, I think, to help make things like PML say, okay, that risk versus the other stuff I'm dealing with, it's the individual's choice. It's not up to the physician. I'm good with that risk. I'd like that drug. Mm-hmm.
But I think the whole point of this is knowing that this is a conversation,
Absolutely.
right? And I can't, neither of us can stand up here and say, well, this is the right drug for this patient. Again, this is truly a conversation that has to be had.
And I think one of the other pieces of that is, so our primary role is to stop MS, right? In the most nerdy, objective, sciencey sense. But there's so much more than that. Going back to goals, setting the bar high, there's a lot more, like fatigue and cognition and stress and mood. And so I always say, if we're shutting the MS down and you're a nervous wreck about whatever side effect from your drug, we haven't succeeded. Right? Your quality of life then is not what it could be. And so I feel like that's not optimizing a person's life. So we have options, right? And so there should be a drug that can be found via conversation that's comfortable for the patient, that they're excited about being on, and that works.
that's a best fit, but maybe not a perfect fit, right?
There's never
Because
a perfect
all drugs
fit, yeah.
have potential for side effects. That's just the reality. And so I think it's finding the best fit that that is so important to do. With that being said, though, we've got really great treatments, and the hope, that we have for every patient with relapsing forms of disease, and now even some of our primary progressive patients finally. But our goal is. Our ability at this point is to stop the disease with a treatment. However, we can't repair past damage. I usually explain to patients, my best offense in regards to treatment is a really good defense and finding the best defense for you, but you still have MS. And this, I think, is where lifestyle is so important. We don't have a cure yet. And I say yet, I hope that at some point in my career we can say that we do. But we don't have a cure. We don't have a way to reverse disability, and that's why we really want to shut things down as early as we can. But with that being said, lifestyle matters, right? If you're smoking 2 packs a day, sedentary, you're going to have major problems, and that's not because of your MS, right? And that's a kind of an extreme example, but lifestyle matters. And so this is something that I spend a lot of time discussing with patients. We actually have really good studies on exercise, and we had talked a little bit about myths that are out there and have been out there for a long time, but for years, MS patients were told not to exercise, which now we know is absolutely absurd. Exercise helps every single aspect of MS: cognition, fatigue. As counterintuitive as it seems, the first conversation I have with a patient when we're discussing fatigue is exercise, right? And I know that they're looking at me crazy and kind of want to kill me, but it's that important and can make that much of a difference. So, and just as with DMTs, finding the right exercise, I think, is a big part of that. But diet matters. There's not an MS diet yet, and I know the MS Society is doing a lot of work and a lot of research is going on in diet, but there's not a perfect diet, but there are certain recommendations that we can make. Michael Pollan is an author that has written a lot about nutrition, and I love his his little, keeping it simple, recommendations. Eat food, meaning real food, mostly plants or vegetables is what he means by that, and not too much. Those are just really simple, good guidelines that make it easy and break this down. You can get into all these complicated diets, but at the end of the day, how sustainable are those things? And furthermore, there's not really the data at this point to really for us to make a hard recommendation on any of the more extreme diets. But I think good nutrition, eating regularly throughout the day, not just one meal at night, but eating regularly throughout the day is important as well. And then avoiding the processed foods, the salt there, and I'll let you speak to the salt and vitamin. Well, we've spoken to vitamin D, but I think there are some real baseline foundational guidelines we can make regarding diet that are important.
And so on that note, there are the Walls diet and blah, but none of them are proven, like you said. And so it's tricky because we all want to push and set that bar high and optimize not only with disease-modifying therapy, but with things that you guys can control. And so what do you recommend? It's challenging. And I think that there's a lot of work going into the gut microbiome because this is how our body interfaces with the environment. We ingest things. Our gut has a lot of immunity to it, so it's sort of sampling the environment that way, and then putting that information into the rest of our body. And so we know with diseases like celiac, there's a clear trigger via diet, gluten. So that's already been linked and proven, and I think that we're not there yet, but we're learning that there are different ways that we're impacting our immune system with our diets. And I don't know, and doing more and more reading, like you're saying, Michael Pollan is great, and I think that mantra is the way that we all should sort of go about it, just because it's so sensible. But if you think about that, MS, as far as we know, it's autoimmune, and it comes about, you can have a genetic predisposition. So you could have inherited some gene that makes you more susceptible. But that it's also environmental encounters that trigger this. And so what is that antigen or thing in the environment that we encounter that triggers our immune system to to develop that autoimmunity. And so we don't know, but I think that things that we ingest could be that trigger. So why not, again, I said I try to maintain optimism, like why not try to change our diet and remove antigenic type things like foods made in factories, right, that aren't real. You're meant to be eating fruits, vegetables, things like that. So those should have a lower chance of creating inflammation and autoimmunity. And so I sort of am even almost recommending at this point, nothing extreme, but looking into things like paleo type diets, which are what Michael Pollan's.
Yeah, so, but also like the just in broader terms, the anti-inflammatory diet. I mean, I think there's some really good nuggets with that to consider as well. So I know we don't recommend a certain diet, but we're certainly going to recommend the fundamentals of avoiding those things that are processed, made that are not real, and really trying to get away from the high fat, animal fat foods, eating more of your lean proteins, vegetables, fruits, and and eating those again regularly, I think throughout the day is important as well. I have a number of patients who eat 1 meal a day. Well, cars can't drive without gas. We can't operate without fuel. So we have to have the fuel to do what we do. And especially when we're talking about fatigue and those kinds of things, I think the way we eat as well as what we eat make a big difference. So. Something else that we've talked a little bit about, though, lifestyle, and I think smoking, I just like to make the point that smoking really is an important conversation to have. Even those who smoke just a little bit, I think it makes a big difference. We know that patients who smoke have quicker disease progression than those who don't smoke. There's been a lot of research on that. Smoking does increase risk for developing MS, so this is an educational point for those who, with those with children, right? I want you making sure that you're aware of this information as you're making your choices as you get older, for those of us with children. But just another reason to encourage that. But also, do you recommend vitamin D for family members?
I do, because it falls into the same thing of, we've never had a study showing it hurts, and we've just had things that show it helps. And so I think why not try? Why not try to do as much as we can? And so it's not something that we prescribe, obviously, but saying, maybe you should have your kids tested for vitamin D levels at the pediatrician or something like that.
Gotcha. Okay, so we're going to turn it over to you for questioning. I think we talked way too long, actually.
Yes. So that's exactly it, but let's give them a round of applause, right? So I'm sure there are people in this audience that have questions, right? Who's going to be the first? I am so glad to see that. Thank you. Her hand went up slightly quicker than yours.
Hey, you spoke of brain atrophy. What is that?
So we know that as we age, our brains atrophy. So basically, your brain develops, right? And you have increasing brain volume, myelin connections being formed, et cetera, until about the age of 17. But then after that, everybody, including those without MS, everybody's brains begin to shrink, and that shrinkage occurs throughout the rest of your life. So there's a certain rate at which brains atrophy that is, I'm going to say, typical for the general population. With MS, though, that rate of atrophy is accelerated compared to general population. And so this is a big area of interest, and there have been, especially with the newer drugs, this has been watched. And how does a drug affect brain atrophy? And we have some medications now that actually slow, one in particular, it slows the rate of brain atrophy down to general population, maybe even a little bit better than general population, which is huge, right? So
I think that it warrants mentioning, again, going back to the disease-modifying therapy conversation, it needs to be a conversation in clinic with a provider who's very comfortable and knowledgeable about these drugs. They all have risks. They're all quantifiable risks and should be discussed, but drugs like Lemtrada or alemtuzumab normalizes the rate of brain atrophy or brain shrinkage as though someone no longer had MS. That's crazy, right? And we said earlier, the other drugs are playing good defense, slowing down the rate of disability progression. For the first time ever, we had to create a term because of the same drug, Lemtrada, that it's some people have improvement of disability. We had to invent that term. That's crazy. So like big changes are happening in the treatment landscape. And so atrophy, back to the question, is one of the strongest correlations we have with disability. So if we're able to normalize that atrophy, what does that mean for disability 20 years down the road, 30 years down the road? And no, we do not have the answer to that question. But it's a conversation worth having.
Next question's here. And by the way, for anybody else that has questions, please raise your hand. Let me acknowledge so I know where I'm running off to next.
Okay, so I kind of have two questions. Okay, only one? Okay. Oh, sorry. Okay, so I heard on National Public Radio, I think about in the last month or so, month and a half, that there's these scientists that found this protein in the brain of people who have MS, that same protein is not in the brain of other people who don't have MS, and they gave it some name, blah, 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 protein number 32 or 35 or something like that. Have you heard about it? And the reason why I'm asking is I had heard that we really can't find a cure to MS because we really don't know what causes it. So we have to find what causes it first to find a cure.
I did not hear that program on NPR. So
it wasn't a program. It's like, you know how they give out, like when March 28th happened and Okra was FDA approved, they announced that too. So this is one of those things they announced 30 seconds or 60 seconds.
Well, I'm just going to say I'm not quite sure.
Yeah,
You ain't heard it? Okay.
I'm not sure what that is. Sorry about that.
Yeah, sorry.
And the second part was?
I have been told that we can't find the cure to MS until we actually figure out what causes it. Because once you figure out what the problem is or why we generally know what it attacks our nervous system, but we don't know what the real true cause of it is. Is it viral? Is it blah blah blah? So they say that once they really figure it out, which these guys say they have, and so I don't know, but you haven't heard about it. So
that would be ideal to find a specific cause. But to me, again, I think there's a genetic predisposition and different environmental factors that can trigger that autoimmune process that becomes MS. Epstein-Barr virus being maybe the best known example, which is the virus that causes mono. So a very disproportionate number of patients with MS have been exposed to mono, whether or not you remember having mono. So clearly there's something about that virus that looks enough like our central nervous system, brain and spinal cord, or parts of it that can trigger autoimmunity in MS. But I don't know that we'll ever find one singular cause.
That's what to say. I think that's kind of the question. Is there truly a singular cause, or is there kind of more of a multifactorial, perfect kind of storm that into MS?
They said that they find this protein, they gave it a name, and the people who have MS and people who don't have MS don't have this protein in their brain.
Well, hopefully they're getting closer to figuring it out.
Yeah.
I mean, I think
and we'll look that up.
Yeah.
I'm interested in that.
I heard you mention just a few moments ago about improvement of disability. I didn't know that was possible. How is that possible? And is there a certain particular disease-modifying medication that causes the improvement?
So I think the first question, how is that possible? We don't know. We have not figured that out. But what we're kind of referring to is there's a medication called Lemtrada that came out at the end of 2014, and their clinical data shows that that there's actually a group of patients in the clinical trial that had what they defined as clinically definite improvement. And this is the first time we've ever seen this with a disease-modifying therapy, which is very exciting. It's really important for me to say, though, in balance, not every patient had clinically definite improvement. And at this point, I don't know that we can predict who is going to experience that. So I think we've got a lot to learn about it, but is that exciting? Why, heck yeah, it is. Yeah. Very exciting.
And we only have 6 years of data from the trial. So at the 6-year data that came out, over 20% of people in the trial experienced an improvement of 1 point or greater on their EDSS score. That's how it was measured. So it is far from everybody, but we've never had that term before because that's never existed in any percentage. So it is a huge deal. That's a complicated therapy that's not right for everybody. But
next question's over here.
Hi, doctors. I don't know exactly how to ask this question, but I understand that...
In English.
Spanish too. I believe I hear that they're working about a medication or a therapy to cure MS, or it looks like it's good and it's projecting a lot of good things about a cure, finally a cure, or maybe a cure for MS. That is true, or it's false?
Maybe stem cells, or
I don't. The doctors said the name, but I don't remember. Your names are always very complicated.
well, the stem cells comes to mind, or bone marrow transplants, this type of therapy. Do you have anything else?
And I'm blanking on the name right now. Biogen. It was looked at in optic neuritis. Talking about what's the name of it? Anti-lingo. I was wondering if she was referring to anti-lingo. The data's not panned out
that was killed.
We had hoped it would. Yeah, there was some hint that there was remyelination seen with that drug, and I don't know if this is the one you're referring to.
I hear also that they are working about curing the myelin, something like that. The myelin, right? So it looks like it can be recovered.
There's a huge amount of research going into reparative mechanisms and how can we, restore some of the disability that was lost. But not too much has panned out, and that was one of the big disappointments. I think there was tremendous hope for that in particular. And I just want to say I was not plugging stem cells or anything like that. That's a huge other topic of conversation, that the goal of that really is cure. That's why I thought maybe you were referencing that. But
it's caught my attention.
So, quick question though, in between the other questions. Have you discussed anything like the similarity between even like Lemtrada and stem cell therapy? Like what the difference is, or how people are getting confused between what they're getting from Lemtrada versus what they're hearing from stem cell replacement?
Well, so this is sort of interesting. What strikes me about that conversation is there's a lot of people, people on the treatment side who poo-poo Lemtrada, think it's horribly dangerous and whatever. But then they're super excited about stem cell transplants and bone marrow transplants, and
those risks are off the chart
it's crazy.
Comparatively.
In some of those protocols, you get Lemtrada to induce removing the immune system in preparation for the bone marrow transplant. I'm very interested in all the stem cells and the bone marrow transplants, but that's not ready for prime time. There's never been a big phase 3 clinical trial. There was some really nice data that came out as recently as a year ago from larger trials, but we're still talking on the order of like a few dozen patients. Almost every one of those trials has had a death in it. It's a very big deal. It's hard to get into those. It's not FDA approved. Now, is it worth discussion with the right patient? Absolutely. But in the meantime, you have this drug that is FDA approved, has been FDA approved, came out in the 90s is when alemtuzumab was developed, and it's been used in medicine since then for many different purposes. It's just not been approved for MS until and really at the end of 2014 and 2015 is when it really started being used. But we've got 6 years of data from the phase 3 clinical trials. There was a pretty sizable phase 2 trial. So I feel like we sort of know the ins and outs of Lemtrada fairly well. All the different, and the other thing about the transplants is that for the most part, they all have different protocols. So they're trying to figure out the way to make it most effective, most safe, et cetera. But we're not there yet.
There's just a lot of work yet to be done. Does it hold the excitement of promise? Yeah, but we are just far from that being available widespread, I think.
Some of the data, though, is tremendously exciting, but yes, we're not there yet.
Okay, next question here.
So I've always been worried about my daughter being able to get MS because I've seen that multiple, sisters or, siblings, stuff like that. Well, I just said sisters, that they have it. Should I be worried and should I test her for anything?
So the risk of a child, a first-degree relative, developing MS is 3%. The general population is less than 1%. So there is some risk, but it's not a huge risk. And I mean, my recommendation to patients with this exact same concern is let's do what we can do, right? So let's, healthy lifestyle, right? Even in youth, making sure she's very aware of the dangers of cigarette smoking, and then checking with the pediatrician to make sure that the vitamin D levels are healthy. So those are usually my recommendations. Do you have?
Totally agree. It's, I'm a parent, I get we're neurotic about all things involving our kids, but there's no screening that you can do. You definitely should not start getting random MRIs or anything like that. Keep vitamin D up. Do not let them smoke. Keep them active and fit at healthy weights, and have them stay active.
Next question here.
I have two questions. The first one is, I've read recently that there is a blood test that they believe may be able to predict MS. Any feelings about that?
I believe I did read one article on this one, abstract, but it was very early in the morning. That's when I do that kind of thing. I guess I do not remember it well enough to really comment.
And I am not aware of that.
It's on my blog. You could check it out.
Okay.
The answer is there. The answer is in the blog. It's one of the stories, all right? All right, I'll be back to you in a minute.
So we need to spend more time on Stu's blog, is what he's saying.
This is kind of a morbid question, but I was watching TV the other day and reading the newspaper, and they said that their wife died of MS. You can't really die from MS, can you? You can die from symptoms, but
more
not.
Typically, it's complications from MS.
Yeah, complications.
So that doesn't mean that you can't have a perfect lesion in a perfect spot, but that is so rare. Where there's actually death to MS. Oftentimes on autopsies, if you're doing historical data, they will say, death secondary to MS, but really it was complications. So it was, patient became septic due to urinary tract infection or whatever else, but usually it's secondary.
Yeah, the three big things are, it's almost always in somebody with very, very advanced MS, and they're at risk for those sorts of things. Urinary tract infection that leads to sepsis, a decubitus ulcer, breakdown of the skin due to loss of movement or lack of movement that leads to sepsis, or issue with swallowing leading to aspiration pneumonia, again leading to sepsis.
Next question.
Previously, you mentioned the study that's underway to take a look at low salt and high salt diets and the impact on MS. What is the timetable to get results from that, and any early results?
I don't remember if that was going to be the end of this year or sometime next year, off the top of my head. But to me, the preliminary data is enough to suggest you shouldn't be eating fast food anyways, right? But don't salt your food. Try to not eat a lot of salty soups that are out and about. Just be mindful. But I don't think anything extreme is warranted, and we don't have the full data yet.
I have a friend with MS in his mid to late 60s, and he is under the impression, I believe he spoke to a physician that he used to see, that has led him to believe that he does not have to be on any type of disease-modifying therapy. He feels that he's maxed out, in a sense, on his MS. Now, he does have gait disturbance, he does have issues, but he doesn't think his MS is going to get any worse, and he has no need to be on any type of therapy for his MS. So what are your thoughts on that? I would like for him to come back and watch this and become educated better.
So what I'm going to say is that falls under the category, if you had a room full of specialists, you'd have that many different opinions on this. So let me preface what I'm going to say with that. what we do know about the immune system, because we know that MS is an immune-mediated disease, the immune system does tend to kind of chill out as we get older. In our practice, we will have the conversations with patients whose disease has not shown any inflammatory type characteristics in the 5 or 10 years prior to their 65th birthday. We'll talk to them about, is this something that you would like to consider trying to come off of? But when we take a patient off of therapy, we never just say, all right, have a good life. It's let's try this, but let's also be very intentional in following you after discontinuation of therapy. So we'll do an MRI usually at least a year out, depending on the patient, maybe sooner. And we also are going to want to know immediately if there are new symptoms, that type thing occurring. So that's our approach to it, and it is a conversation we have with certain patients. I will tell you though, we've had patients that we've had to put back on therapy when we do that. So, but that's usually in our practice, we've kind of picked the nebulous age of 65, but that's when we will have that conversation.
And I'll just add a couple quick things. Stephen Krieger he's out of Mount Sinai, New York, has this beautiful model. You can Google Krieger swimming pool, and is it on the blog?
The leaky pool.
The leaky pool.
Yeah.
The leaky pool.
So this, I mean, I just think this is revolutionary in terms of how we think about MS. But one of the things, so I won't get into details. One of the things, though, it talks about SPMS, secondary progressive, so-called. You still can have attacks at that stage, even if it's been 10 or 15 years. So does that mean it warrants treatment? I'm not saying it does in all cases, but we also know that brain atrophy is a big part of that phase of disease, or what we label as SPMS. Some of our drugs protect against brain atrophy and have pretty darn good safety profiles. So I sometimes have that conversation, like, do you want just a different sort of insurance policy? You're not talking about doing many of the therapies at that stage, but some of the other ones might be appropriate.
So this leaky pool that he's talking about, yes, developed by Stephen Krieger, but Aaron Boster did it for us at a couple of our programs, one in Ohio, one in Florida, and it's on our YouTube channel. So you can go on there and just look up the leaky pool, and it is fabulous. I mean, it's a very detailed description, which your 5-year-old can understand also.
But it also makes a lot of things make sense. I mean, it's just a really great way to understand MS, I think.
You mentioned the ESS scale. You started at 6 and was saying something I didn't really comprehend what you was saying. You were saying like it's going downward, going to 10, or could you read?
Yeah. So this is the thing, right? This is how clinical trials all operate. They have to have this EDSS. It's a 10-point scale from 0 to 10. 0 is no disability and 10 is death. So each number you move is a big deal. And 6 I use just because that's the stage where you either have trouble walking the length of a football field, or you're walking with a cane or some sort of aid. So if you can go from a 6 to a 4.5, where you're walking multiple football fields with no cane or other assistance, that's a huge difference in quality of life. So the EDSS is not done at every visit, and it's not probably done in every office, but it's something that should be done annually to sort of help us. It's another way we can track disease. If you have a big change in that, even if you haven't had an attack, that's a problem. So that's a little bit about the EDSS, and as the guy who invented it said, it's like democracy. It's not perfect, but it's the best thing we've got.
They've been trying to come. It's heavily based on ambulation, the EDSS, meaning how it's scored is really very much based on ambulation. And so, I mean, there's been lots of arguments about why that's not ideal, but nobody's come up with anything better. So
yeah, because it misses cognition, thinking function and memory function, and it misses fatigue and other things that have a huge impact on quality of life. It's very skewed towards how well someone's able to walk and get around.
Next question is from back here.
I had optic neuritis back in '96. At that time, MRI determined that I did not have MS. After relapses in 2011, the MRI determined that I did have MS. And I was put on the old drug Avonex. And I've been very, stable with that, with my MRIs. My question is, tagging on to the aging out question, I'll be 64 this year. And Avonex is not approved under the Medicare program at 65. So should I be thinking about switching to another drug come 65, or not doing anything at all?
So I think that's truly a conversation to be had with your neurologist and getting into the detail. But you kind of hit on some of the reason we also have this conversation, which is the insurance part of this, right? Good, bad, or indifferent, insurance does inform our treatment at times. And so oftentimes patients will bring this to me and say, hey, after 65, it's not covered. And so that's where we can have this conversation about, for their care, for what we've seen with them, what is the best way to move forward, whether that be switch, whether that be whatever it is.
Before I take more from the audience, I have a new question to bring you. Comorbidities. What can you tell us about that?
People with MS are people.
They don't know. They don't know. This is a new topic for them.
It's really big a topic. So there's actually, we see with patients with MS that there is an increase in heart disease, obesity, different factors like that. And it's not that the MS caused that. Maybe it's a downstream from the MS. Maybe patients aren't as mobile, they're not getting as much exercise, etc. But it's imperative that we pay attention to those comorbidities, healthy weight, especially in those who are non-ambulatory, right? That can be a big challenge. So how do we achieve more of a healthful weight that's going to be placing that patient less at risk for cardiac or events, stroke, etc., diabetes, all those different things. But some of these comorbidities can far outshine my concerns about their MS. I'll have patients sometimes, who are diabetic and their blood sugars are, all over the place. Diabetes affects every single system of your body in very not pretty ways. And so it's imperative that we get those things controlled, blood pressure, all those other risk factors. So really kind of separate from the MS, but also will impact the MS, it's imperative that we address those other health concerns. And that's where our primary care colleagues can be a huge asset to the team that any patient has. What would you like to say?
The same.
Okay.
Yeah.
Didn't know if you had anything else to add.
Okay, who else had a question? Oh, there we go. I have MS and I forgot.
Back to brain atrophy. You said that there's something, a therapy that may help it. And number 2 question is, do brain games work? To sit there and try to exercise your brain, is that helping your MS?
Go ahead.
We think that, and a lot of that data, there is some data for that in MS, but there's data also for that with regards to cognitive, like Alzheimer's and things like that. And it's just like your body. The more you exercise it, the better it will perform. So yeah, we absolutely recommend brain games, crossword puzzles, reading, stimulating conversation, being socially active, because it is important to use your brain. And brain atrophy, we have no way to reverse brain atrophy. It's just a matter of if it's destined to, decrease at a certain rate, are we able to slow that rate?
Because again, everybody's brain atrophies. I mean, even those without MS, that's part of the human condition. Yeah. The MS just accelerates that.
Question, can we slow it down? Yeah, so yes. All 3 of the oral pills have data for that. All the injectable therapies have data for that. None of the injectable therapies have data for that. The infused medications have data for that, and the best data.
Next question here.
I'm aware of the fact that the Tisch Center in New York City is performing stem cell trials that are not full replacement. They're not HSCT. Were you aware of that?
Yeah, so those sorts of things are going on across the world, different ways of using stem cells to try to change the way the immune system's functioning. There's ones that take them and inject them directly into the CSF, the spinal fluid. Some of those are being done in Israel. So there's tons of interest, I think, from everybody in finding the best way to perform that sort of a thing. But again, and in certain patients, it's probably worth having that conversation. Like, you might want to consider this. But
for an idea of who is doing what types of trials, you can go to clinicaltrials.gov and find where those various trials are occurring. They're not here locally, but there are in the larger research institutions. You can find those trials and find if they're recruiting, if you feel that would be applicable to whomever.
Okay, I have two questions. The first is, when you're in a therapy, how do you know that it's any way you know that it's working or it's not working?
So we keep kind of throwing out this term of NEDA, no evidence of disease activity, and that's what we're trying to get at, that question, is the therapy working? And so what we're looking at, those different endpoints that he went through, so we're looking at MRI, we're looking at, are you having relapses, disability progression, all those different things. And if we can say that we are, we're not seeing those things, then the thought is that the drug is working.
Okay, but that's on doctor's view. What about the patient? How we, the patient knows that's something, because we don't.
So
for example,
I think
I don't
that's
know.
where it comes down to just the conversation, right? Because we can present what we can present to you, but then your input on that is equally important. And so that becomes a more individual conversation. And I hope you've heard that throughout the communications that we've had today, is that there's no one size fits all. It'd make everybody's role and jobs more easy if there were. This is truly an individual disease in which, we can give you the information we can give you, but at the end of the day, your opinion weighs equally on that. And, if a patient feels it's not working, maybe that's just this, kind of the sixth sense, then, okay, let's have a conversation about that. What do we need to do to address that?
absolutely, and you're not stuck with the drug. That's the other thing. You can always change. Thank goodness we have options now, but I totally agree. It's a conversation to be had.
Question here.
Okay, so March 28th, they approved Ocrevus, and I think the predecessor to Ocrevus was Rituxan. So what is the main difference between Rituxan and Ocrevus, other than Ocrevus is FDA approved, and therefore your insurance should be more apt to pay for it than Rituxan, which is really expensive.
And that's probably the most important point, actually.
Yeah.
But, you can go ahead.
Just really, they both attack CD20 receptors on B cells. They're both dosed the same frequency. They're both IV. They're both highly effective. They made ocrelizumab different by humanizing it. So it's the way that the molecule's built. It's more similar to human-related DNA products, and so it's supposed to be better tolerated and technically different, and then can get approved.
Yeah, but less infusion reactions, that type thing is the thought that you're going to see.
You touched earlier very briefly on how you have to eat to maintain fuel for your body, and eating one meal a day is probably not sufficient enough. However, I have a friend that bounces back and forth between vegan and being vegetarian. She eats only one meal a day with snacks. I'm trying to figure out a way to let her know that that's not healthy. She seems to think that she's healthy. She's in good shape. She gets around well and everything, but she doesn't go to the doctor. She does not take medicine. And she thinks she's healthy. She thinks what she's doing is okay.
If you can figure out how to change behaviors in other people, we would love. We would love to talk to you further. I mean, I think the big thing here is when I'm talking about diet, I'm usually talking about it with someone who's already having issues. They're coming to me saying, I'm having fatigue, I'm having XYZ, and this is really where the conversation about that begins. So if I've got somebody who's just struggling with fatigue, I'm going to look at a lot of different things: sleep quality, diet, all these different things. And so that's really where that particular conversation often begins in my practice. And so, especially with the fatigue thing, that's where I kind of go with, if you're just eating once a day, that's probably part of the problem. Or if you're eating a bunch of high sugar foods, you're just crashing all day long, those blood sugar crashes. And so that's really where it comes up most often in my conversations with patients.
All right, so nobody else here seems to have a question, but I was asked to ask this question, and I do not know how comfortable either of you will be with the response.
Oh, no.
But no, yeah, here we go. You ready? So, exactly.
Yeah.
So the question is somebody wants to know the difference of what they should be doing with CBD oil versus medical marijuana, which has the THC, versus the CBD, which does not have the THC, which is the stuff that makes you high, all right? And the CBD oil is actually hemp oil, and hemp by itself is legal everywhere in the United States. Your opinions, please.
My opinion on that is that we've got a lot to learn, and currently in my practice, I'm not prescribing the oils, and so I don't have an opinion as to how that works in my own hands. And what I mean by that, and we actually were talking about this before the program began, we've talked about the trials and the different things that inform our behaviors as clinicians. But also what we didn't mention that informs our practices is our experience. And so I think that until I get experience with something, it's really hard for me to give an opinion about what my thoughts are.
I agree. There's been studies about marijuana in MS, and it's shown to improve MS-related pain and to MS-related spasticity, but it's also shown to worsen cognition. And then I think that, the CBD oils hold promise, but pretty much exact same response. It's not something that I'm actively prescribing. I'm curious about it, but I don't feel we quite have the data to make me want to go to that yet.
Sorry, I had to ask it,
That's fine.
All right. Anybody else have a question? Anybody learn from this today? Oh, you have more questions? Wait. One more.
I just wanted to touch back on that friend that only eats one meal a day. Now, she, as far as I'm aware, she doesn't have fatigue or anything like that, any major issues. So you think she's okay and totally healthy to eat only one meal a day? Do you think that's okay?
That's as bad as asking about CBD.
I don't know your friend. I don't have your friend's medical history or any of that. So I can't comment on that. But if your friend feels that they're doing fine, they're probably not going to be very motivated to make any changes. That's probably what I would say on that. And again, if you can figure out how to influence behavioral change, please let me know, because I would love to take notes.
Okay, another one over here.
Okay, that hemp oil that's I think it's supposed to help pain, and you're saying it's that marijuana oil is kind of like really it's based in hemp or something, because marijuana is in the hemp family. So can you maybe like try hemp milk first to see if if you don't get crazy off the hemp milk, that you'll probably be okay on the hemp oil?
I don't know what's in hemp milk.
You're right. Well, and I think it's going to be, nobody can make recommendations about how one thing will affect you versus another. That's going to be a very individualistic response regardless. So there's no way that we could even answer that question, and not to mention the fact there's no data on that. So.
Yeah.
I got another question across the room, though. And I can't go in front of the cameras, so.
You're getting your workout, aren't you? Your 10,000 steps.
I've been burning. I need to burn a lot of fuel going on lately.
You talked about treatments that you use for relapses. Is there a particular one you would use with Gilenya, considering the risk with steroid use?
So well, we can both speak to that, but what I will say is we try not to give steroids to patients who are on Gilenya, and the reason for that is steroids are an immunosuppressant, as is Gilenya, and there's increased risk for serious infection with that. So we try not to do that both. But what I'll also say, the really good news is I rarely have to treat a relapse on Gilenya. So that's not something we have to do very often. I think if you're truly having a relapse on Gilenya, there's several different things that need to be considered as to A, why that's happening, and B, what the long-term solution to that is. So I don't have a specific recommendation because that's going to be such an individualized conversation.
Yes.
Nothing?
Agree. I try to not talk when possible.
Okay, great. So everybody okay with what they saw and heard today? Great. I want to thank you both for coming on down. It was great. I appreciated it, and I hope you all enjoyed it too. And again, I want to thank Teva for giving us the funding to do today's program, and I'm sure we all be very thankful that we were able to do this with Teva's dollars to do it today, okay? Thank you, everybody.
Thank you.